Done,
analyze.
done.
Thank you, sir. Yeah.
Shilpa madam, I am क्या बोलते this thing in RPL. Okay.
Champion, sir, you're.
That is because of my background history only. So RPL तो तुम चालू हो जाओ.
Yeah, yeah, I know. Yeah, you have mentioned
हाँ.
it times. Okay.
Yeah, चलो चलो आरती करो. We are live on Facebook. अरे
Okay,
YouTube, sorry.
1 minute. I'm just going to share my screen.
1 minute. I have to give that. This new phone, no? I have. चलो.
Can you see it? My screen?
Yes. Yes, madam.
Super. Good evening, everyone, and welcome to today's session on the overview of recurrent pregnancy loss. And why, all of us, our team here, thought that this topic is very relevant today, you should know, because it is a challenging clinical scenario. And as Shilpa rightly said, there is, there's so much of evidence out there. Either people are not doing anything about it or doing too much about it. And there's no good quality evidence. There's so much of controversy. There are no proper recommendations. There's so much of variation in terminology, referral criteria for RPL services vary as well. So there's so much of lack of consensus. So today, again, we are not going to be talking too much of theory. It's going to be more practical take-homes as to what is it that we do in our clinical practice when we face a patient who has had recurrent pregnancy loss. And, this beautiful saying applies especially in patients who suffer with RPL. And that is, the more I learn, the more I realize how much I don't know. So with this as the basis, Jay, this is the case who came to us. A 28-year-old female, non-consanguineous marriage attempting pregnancy since 3 years. History of 3 previous miscarriages. And you can see here the 3 pregnancies were first trimester pregnancy losses, which happened at around 5, 6, and 7 weeks, where there was no fetal heart in the first 2 pregnancies, and the 3rd pregnancy was an embryonic pregnancy. And the last pregnancy was around 5 months back, and now the patient wants to start trying, but wants to know why this is happening. The basic tests were done by her previous gynecologist with just a CBP, thyroid, and a random blood sugar. No other evaluation was done, and the patient is on folic acid since 3 months. So this is the patient who came to us, and many of us face, such patients daily in our practice. And we did an ultrasound. You can see here, Jay, the uterus looks normal. We did a 3D ultrasound as well. Everything looked okay. The ovaries looked normal. Antral follicle count was around 8 to 10 on both the ovaries. Absolutely normal pelvis. This was a baseline scan.
Madam, now, what day of menstrual cycle was she scanned on?
This was a baseline scan, day 4.
Day 4. Okay. No, because it's that endometrium was little secretory, at least from what I could see, or maybe some blood products or something. Maybe, okay, nothing.
This is 5 months after.
The good thing is that 3D is normal.
Yes. And now these are the questions. They're very basic questions. Today we're only going to cover absolute basics. So,
done.
Yeah. So these are the questions, Jay. You can take it forward, and I'll keep asking in between whenever I, think I should ask you something relevant.
Yeah. Fine. See, one thing I want to tell very openly, and there is no guideline to this, but I just want to share this. Okay. See, though we know and we all understand that having the a first abortion post marriage, okay, can happen to a lot of women. Okay, a single miscarriage is no indication to evaluate further, or or to treat or anything like that. Correct? People say that even the second miscarriage out of 100 can happen to, let's say, 20% of the women, and they can still have a wonderful chance of conceiving after that. Okay, but in today's time and age, I'm talking of 2023 as we are in. Okay, I don't really know when and where was this guideline made, that one must evaluate somebody after second or third loss of fetus. Okay. And then, if there is an age factor that let's say somebody is 35 or let's say 37, then maybe after two losses. Okay. But I think what I do in my practical experience or in my practice is slightly different. Okay. I will not wait for somebody to undergo the third miscarriage. Okay. First miscarriage is okay. First miscarriage, definitely, apart from madam, what you have done, TSH, thyroid, what you've tested for, okay, CBC, prolactin. I will also add an AMH in today's time because it is very common to see low AMH in an idiopathic recurrent pregnancy loss in an Indian population. So I would really do that. Fortunately, you have done a 3D ultrasound, but that is a baseline parameter which we evaluate, okay, for everyone. And sometimes you may pick up a septate uterus or anything like that, an anatomical cause basically for abortion, where you don't really have to wait for three. If you've picked up a septate uterus in the first abortion, you must go and clean. I mean, you must go and do a septal resection, excision, whatever you want to do. Right. So that is an important take home point, I think. All right. The second thing which I'm very firm about is that it's very tough for a non-medical person to go through an abortion. Okay. It's very tough. Okay. Even if you were to be a cardiologist husband and a radiologist wife and not a gynecologist, okay, then going through one and two abortions in marriage, especially without having any living children, is a very tough thing to do. Okay. So one can't really expect these couples to just wait it out for the third thing. So in practical life situations, I guess after the first or the second, one must at least do a basic run of investigations. The advanced investigations to be offered only if there is this repeated history which you just right now mentioned, madam, but I would investigate much earlier. So that is the first thing. The only thing which I would not take into consideration in this is what is mentioned here, these biochemical pregnancies. These biochemical pregnancies, people come and tell us कि अरे वो किट पे पॉजिटिव आया था अभी पता नहीं है. So that kit पे पॉजिटिव आया था is due to either a concentrated urine or due to a defective kit. Okay. Because as long as there is no sac which is visualized, that is not to be considered as a pregnancy, and that doesn't deserve sort of any form of investigation only, in my opinion. Okay. But yes, so coming back to your to that flow chart which you had asked me the questions, I would start a little early. I don't wait till 3. I would actually start telling people that first time they've had a missed abortion, after everything is settled down, okay, you can come and we will do the basic set of investigations. And then if there is a second abortion, I will proceed with the next set of investigations. Okay. So your second question is overview of the causes for recurrent pregnancy loss. So I think okay, though we have tried to divide this in our textbooks into many things, for practical purposes, I just divide it into two things. Okay, either there is a known cause or there is no known cause. Simple. Okay. Now this known cause theory can be anything. It can be your hemophilia. It can be protein C, protein S. It can be infection, hormone, endocrinology, Y chromosome. मतलब आप जो भी बोलो, chromosomal abnormality, whatever you talk of, okay, all of that comes into this category, madam. Okay, that it is you know the cause, okay, and all of it which is exceeding this, okay, comes in the category of idiopathic. Okay, because remember, idiopathic is a big category. This idiopathic recurrent pregnancy loss probably constitutes 60% or 70% of the pregnancy losses which we see. Okay. It's only these 30%. We give so much importance to testing for protein C, protein S, anti-nuclear antibodies, anti-phospholipid antibodies, anti-beta 2 cardiolipin, anti-beta 2 microglobulin IgG, IgM, anti-cardiolipin IgG, IgM. Okay. And it's good. I mean, really, it is good to test. But what is it?
Let's go.
The treatment for all this is to give ecosprin, no? So, I don't really know if yes. So, if we were to do evaluation, for these guys. And if I were to talk of males first, the simplest thing is to include DNA fragmentation index in a semen analysis. Okay, it is semen analysis plus DNA fragmentation index. These are the two important things because that will give you a big idea of how things are. Okay, you don't really need to go and focus on the hormonal parameters of a male partner, because if the hormonal parameters are abnormal and the semen parameters are not abnormal, then it is completely okay, right? As long as the semen is normal, male partner doesn't require further investigations. Okay, but please do a DNA fragmentation, and doing a DNA fragmentation will start adding a lot of value to your. Why I'm being so specific about DNA fragmentation is that, see, in many cities there will be, there is this trend of doing LIT for the first abortion itself. Okay, but what typically happens is, if you evaluate these patients nicely, you will notice that 30% of the males, after two abortions, have had a DNA fragmentation of more than 20%. Okay, just treat that male partner nicely. Within 3-4 months, they will conceive and they will have a normal, nice, natural, beautiful pregnancy. Okay, probably any which ways LIT is not indicated in such situations. Okay, and an unnecessary LIT can be prevented in something like this simply by adding a DNA fragmentation. So please give a lot of importance to doing a DNA fragmentation is what I think. Okay, in these type of situations, and please add it in your parameters. Okay, that is for the males. Coming to the females. Okay, so females, probably you try to divide it into 2-3 lines of investigations. Okay, so one is the blood investigations. In the blood investigations, as we already mentioned, you do a standard CBC, you do the hormones AMH, TSH, prolactin. Okay, important to do these three hormones in my opinion, because all three of them can have an independent link to having recurrent abortions. Okay, fortunately, at least in metro cities, with a lot of these health checkups, okay, these people end up doing TSH easily once in a year, right? A lot of good people. So people know about their thyroid situations. Okay, you will be surprised. You will pick up a lot of diabetes mellitus type 2 in this evaluation. Okay, for recurrent pregnancy loss. So please keep that in your mind. We always do an HbA1c. Okay, in the place where I am. Okay, so as you know, I am based in Bombay, and in Bombay, I specifically do get, because I'm a Gujarati, I do end up treating a lot of patients who have thalassemia, sickle cell anemia, and all these things. So when I end up treating these type of patients, it is important for everybody to understand this, that we test for hemophilias. Okay, so we do a hemoglobin electrophoresis for a lot of patients. Okay, but it is not a mandatory investigation which you should do, but we do it. Okay, so this is just one additional thing which I do, which is not mandatory, which is based on the type of subset of population which you are treating. Okay, then comes the radiology. So we always do a 3D ultrasound. Always. Okay, it is an always that we always do a 3D ultrasound. Okay. And then finally, I want to say one more thing about the blood investigations, that we never do torch. Okay, we have never done torch testing for recurrent abortions. Okay, I know it's going to sound bad, but we never do it. Okay, torch is, it's so funny, toxoplasmosis cytomegalovirus is endemic in India. Okay, so if you're torch IgG positive, and if you're cytomegalovirus IgG positive, it's a great thing. God has already protected you from every damn thing on earth. Okay. Rubella, yes, some people say that, okay, rubella ka testing, you've not done, so we have to test you for rubella and all these things. And if not vaccinated, then you need to take a rubella vaccine, because which is a live vaccine, and then you wait for a month or so before you become pregnant. But that is not a cause of first trimester abortion. That is predominantly done to prevent a rubella infection for the fetus. That has got nothing to do with abortions. Okay, so just keep that in mind. So we never do that. We never do torch testing, because a lot of people recommend it, and in cities and in places where you have a lot of physicians, family physicians who are also into practice. Okay, so I know that in South India, family physician practice is not very high. But in Maharashtra and in Gujarat and in all these Rajasthan, all these places, there are a lot of family medicine guys who also practice basic gynecology. Okay, so when the patient goes to them, they routinely write torch investigation, not their fault. It's just that they have not been updated to it. Okay, but remember one thing, torch should not be tested as a part of your first trimester abortions. Okay, we test for torch. I test for torch when there is a hyperechogenic bowel. Okay. So that's a fetal medicine part. Right? 16, 18 weeks when the bowel is hyperechoic, we think that there could be a fetal infection, which is why we've tested for IgM. Okay. And then we look into the affinity and all these things. Okay. But otherwise, we don't indicate those type of tests. See, we don't do protein C, protein S factor levels. We don't do these type of evaluations for all patients. Okay, these heavy blood evaluations for all patients, we will only be doing them for patients once all these things turn out to be normal. Okay, then that second line is to evaluate the patient for antiphospholipid antibody, anticardiolipin, IgG, IgM, and all these things, anti protein C factor deficiency, protein S factor deficiency level, and all these things. We don't do it as a first line of investigation. Okay, so this is just my thing on how I evaluate. The reason why we don't do it, because the amount of population in India who has protein C and protein S. Okay, put a hand on your heart and tell me how many patients of protein C factor and protein S factor deficiency have you treated and delivered in your entire obstetric career? Okay, so if you answer this, no, out of 100 people or 200 or 300 people who are attending this seminar, only one will be able to put up their hand. That is because if you ask a hematologist, he'll tell you it is not so common. Okay, it is not so common in Indian population it is not so common. So just keep that in mind. We don't do it. Okay, but and not as the first line. Okay, so this finishes the tests probably, which I would do, and I would do one more thing which has not been mentioned and listed, but I do it very routinely, and that is the reason why I was asking Aarti madam what day of menstrual cycle is she on. Okay, so for recurrent pregnancy loss, a big factor in India is endometritis. Okay, a big factor. Okay, it is not a part of any guideline, but yeah, we see it so commonly that I can't tell you. Okay, so what we do is once we do a 3D ultrasound, on that 3D ultrasound, okay, you will have this little idea. Okay, you will have this very little idea that okay, something is wrong, in that endometrium. So you will ask, how will you have this little idea? You will have this little abnormal fluid pocket, which is typical of chronic endometritis, which is seen. We've discussed this in fluid in endometrial cavity masterclass. Okay, you will have this uterus, which has this little collections, loculi of collections on the outer myometrium, sort of indicative of PID, little bit of fluid in the pouch of Douglas. In this situation, no, if you just do an office hysteroscopy, so if you have the facility to do an office hysteroscopy, then it's the greatest thing on earth. Okay. If you think you don't have the facility to do an office hysteroscopy, just take a pipelle biopsy. It is a simple endometrial biopsy, does not require any anesthesia. As soon as your TVS probe comes out, your pipelle can go inside and take a beautiful biopsy and come out. Okay. And once you do this biopsy, then it will make a big difference to your practice. Okay. So obviously, I mean, myself and Dr. Aarti have had this discussion, and we've tried to act on it. That I've tried to incorporate a protocol which she follows on CD138 testing. I don't do it currently, okay, but we would like to send an endometrial biopsy in recurrent pregnancy loss. So we do it very routinely. We do it much before we do the protein C, protein S testing. We do this endometrial biopsy and office hysteroscopy, and that takes care of like 99% of the people. Okay, 99. All right. And if all that is normal, that means the patient is having an idiopathic RPL and you are going to be in trouble, because idiopathic RPL is very difficult to treat. Okay. Very, very difficult to treat. One more thing I want to answer. It's a common patient query. It is not a medical query. Is that my husband and we both have the same blood group. So is it going to affect? So there is nothing like that. My husband and me have a different blood group. Is it going to affect? Nothing affects. Okay. All that is absolutely fine. That doesn't really cause a recurrent pregnancy loss. Okay. So yeah, this is what probably I wanted to speak from my practical experience. And Arti madam can answer now.
Right. Jay, so those are very nice take-home points. So just putting a structure to whatever was asked and what you have just mentioned. One, when do you start investigating? Though different guidelines give different recommendations, two or three, after 2 or 3 consecutive pregnancy loss. I think a take-home is that we need to start investigating definitely after 2 pregnancy losses. Another take home is when you count a pregnancy loss, ectopic and molar pregnancies should not be considered into this definition of a pregnancy loss. And talking about the overview of causes, you beautifully mentioned, there are 2 causes. One, either it's a known cause, or two, it is an unknown or idiopathic cause. That's how you had mentioned that you classify the reasons for pregnancy losses. And just a rough structure of why pregnancy losses happen: genetic, infectious, endocrine, immunological, anatomical. So based on these causes you just mentioned, for a male you would want to do a basic endocrine testing and semen analysis. A DNA fragmentation index test is what you mentioned. And coming to the female, 3D ultrasound to rule out any anatomical abnormalities, endocrine testing to rule out diabetes or untreated thyroid dysfunction. We'll just talk in a bit about genetic causes and when would you want to do a karyotype or products of conception. When would you want to genetically analyze the products of conception? Your take on that. And you also mentioned beautifully, for a female you would divide the blood tests into 3. One is blood investigations, 2 is an ultrasound scan, and 3 is an endometrial biopsy. So you also mentioned that thrombophilia testing you would not really want to do in everyone. You mentioned first line and second line investigations, and importance of a torch test is also what you had mentioned. And I think that is your investigation advice on patients who have recurrent pregnancy loss. Now, just one more thing, Jay. If this patient was pregnant again and again miscarried at around 7 weeks, would you advise a microarray test for the products of conception?
Uh, yeah, I mean, after the second one, after the second abortion, okay, or in the second abortion. See, the first abortion, we don't give this choice, okay. From the second, we start giving it, okay. One must remember one thing, that when you do a microarray product of conception, uh, it's important that this product of conception is collected correctly. That is the first thing. Second, it is important that there is no contamination. So you please plan for POC karyotyping much before you do the DNC. It should not be a surprise DNC with surprise collection. When that happens, no, almost always there will be maternal factor contamination. Almost always there will be a situation where the products could not be interpreted because the culture could not be done. And this, if you want to do POC karyotype, it's important that you follow a good guideline to it. All right, that is the first thing. Second, remember, if the POC karyotyping turns out to be normal, that means it tells you that it's a normal fetus. Okay, then you are in trouble. That means that the fetus was normal, euploid. Let me just put it that way. It was a euploid fetus which got aborted. Okay, that's a bad thing. Okay, that means that something is wrong and you need to look in the endometrium or anatomy. That's it. Nothing else causes a euploid fetus to get aborted. Very simple guideline. Okay, if the POC karyotyping is abnormal, trisomy 21, trisomy 18, monosomy 3, trisomy 9, whatever report is coming, you should be the happiest person that God or nature took care of an unhealthy fetus and aborted it. Okay, but usually in that situation, you should recommend the couple to undergo genetic evaluation. Okay, a karyotyping of the couple. See, karyotyping of the couple. Remember, it's a very simple test. It hardly is going to cost the couple 6-7 thousand rupees. Okay, and it gives you a rough idea of a broad arrangement of the chromosomes. Okay, it doesn't really look into any details. It just gives you a broad arrangement, numerical defects, inversions, absent length at particular level, inversion, all these type of things you will see. You can't really go down to the genetic gene level, basically, in a routine karyotyping. Just keep that little point in your mind, because the commonest thing which people ask even on WhatsApp as far as POC karyotyping or karyotyping is this, that shall I do karyotyping or shall I do whole genes, exome sequencing. Just remember, the cost difference between the two of them is 5 to 7 times. So not everybody is going to be able to afford all these things. Okay, so that is one thing which you should keep in mind. But yes, I will advise a POC.
A comment over here, Jay. I mean, we do it, we offer it to our patients who've had recurrent first trimester miscarriages. If you give it in a standard lab, they always do an MCC test before they actually release the final
Yeah,
report. They look for maternal cell contamination, and only once they clear the MCC test are the products of conception then put through the micro.
you will get an email. You will
Yes.
get an email that there is no contamination. That's why we are going ahead with POC karyotyping. Otherwise the sample will be rejected. That to excessive maternal contamination, further processing cannot be done. QA/QC failed. That's how the reporting is normally.
Right, right. Now, what about psychological support? I think this is very important when these patients go through so much.
No, no. I think we'll take it in the next class. It's already 40 minutes, which is gone. I think we should try to contain our classes within half an hour because RPL is going to be very interesting, and we need to really spend some time on all this. See, the
Right.
only two things which I want to add is the age of the patient and whether it is infertility treated conception. So I think these two factors make a lot of difference when you start your evaluation, and the psyche of the patient, like the couple, will be very different when you deal with patients who had a miscarriage, especially after infertility treated. So the rest of the things, I think, yeah, Dr.
Take
Apni
it
would.
next time. I just want to, I think we'll take the
Yes,
rest of the things. I had actually some interesting data, but I'll share it next time on
yes,
what is the terminology to be used when we are reporting a
yeah, yeah,
miscarriage and how to report a miscarriage. When do you actually give up on a pregnancy?
yes,
I'll take that in another session. But before I end, I just want to share these two slides. I think all of us have to, should have this sort of a data just under our desk, because patients tend to ask us what is the risk of a repeat miscarriage if they have one or two or three. So, this, of course, these are just numbers, but patient want to know numbers. If they've had 3 miscarriages, then the recurrence rate is going to be higher. And as you just mentioned, Shilpa, age of the woman is very important. So based on the age of the woman, what are their chances of miscarrying is again another information we should readily have, so that we can provide this to our patients and we can give them a realistic information about what to expect. So I think with this, Shilpa, we'll end today's session. But as you said, there's so much in RPL to discuss and talk about, and we'll do that in the upcoming sessions.
yes, ma'am. Yeah. Thank you, sir. Thank you. It was wonderful.